Okay, hi guys. Good evening. Welcome to this Prof Exams Made Easy session. We'll not waste a lot of time. We'll jump into the pharmacological perspectives of organophosphorus compounds poisoning. Okay, so where are we? Are we going to be explaining that in detail? No, we're not here for that because we are primarily targeting the university examinations. We'll keep it as simple as that. The notes which we're going to be giving will be having 2 diagrams, will be having 1 or 2 flowcharts. Well, you just need to replicate the same notes in your exams. Very much damn sure that you will be getting the maximum marks out of it. Of course, it's going to be very much crispier, so please be ready for it. Organophosphorus compounds poisoning. First of all, before explaining about organophosphorus compounds poisoning, we have to know what exactly is an acetylcholine. Consider here is where your cholinergic neurons. We have vesicles which contains acetylcholine in it. When the impulse comes down from the brain, there will be release of acetylcholine. Yep. This acetylcholine will be interacting with certain areas which is present throughout the body. It might be certain smooth muscles or cardiac muscles or blood vessels, anything is gonna be. On the surface of certain muscles, there will be muscarinic receptors and there will be nicotinic receptors. Again, I'm saying you just need to replicate the same notes which I'm going to be providing that in your exams. That will be enough. So this acetylcholine will be binding up with the muscarinic and nicotinic receptors. Thereby, this is responsible, especially the muscarinic receptors are responsible for a bigger list of symptoms to be seen. How can we remember those symptoms? Of course, there are lots of mnemonics which is provided by your professors itself, like dumbbells and SLUDGE BBB. Again, we're going to be following that SLUDGE BBB mnemonic. So SLUDGE, SLUDGE BBB is the mnemonic. S is for salivation, L is for lacrimation, urination, diarrhea. GI motility is getting increased. GI motility will be increased. In eyes, there will be miosis. And patients might land up in emesis. B is for bronchospasm, which means patients might be having respiratory difficulty. There will be bronchoria. And last B is for bradycardia. Of course, you just need to remember, again, it is not needed to write it up in your exams, just for your understanding purposes. SLUDGE BBB is there. SLUDGE BB is due to muscarinic M3 receptor, whereas the last bradycardia is the only one which is due to M2 receptor stimulation. Whereas all the other activities are due to M3 receptor stimulation. Okay. So because of acetylcholine which is getting released, which is binding up with muscarinic, patients will be landing up in SLUDGE BBB symptoms. But it is not going to be happening throughout. So we need to have certain mechanisms of how to break down this acetylcholine molecule. That's a physiological thing because acetylcholine is an ester molecule. So we have an esterase enzyme. So here is where your acetylcholine esterase enzyme, which will bind with this acetylcholine and tend to break down acetylcholine to acetic acid and choline. Acetic acid and choline. This is how the acetylcholine is getting metabolized. Yes, hi Hemant. Hi, good evening. Yep. So acetylcholine is getting broken down by the acetylcholine esterase enzyme. Good of them. Now we'll proceed on further. We'll be looking into how exactly this particular process is happening, how acetylcholinesterase is binding up with acetylcholine. We're going to be talking about that. So we'll be explaining that with a simple diagram nearby. So consider here is where your acetylcholinesterase enzyme is. It contains 2 sites, my dears. The acetylcholinesterase enzyme, which we have drawn it over here, contains 2 sites. The first site is called as A site. The other one is called as E site. A stands for anionic site. E stands for esteratic site. This in turn will be binding up with acetylcholine. Again, acetylcholine will be having 2 sites for the easier binding of acetylcholinesterase enzyme. So whenever this molecule is coming and binding with the anionic and esteratic site, the acetylcholine is getting broken down. This is the normal physiological mechanism, my dears. So whenever a stimulus is coming up from the brain, like your cranial nerves 3, 7, 9, and 10, which are the parasympathetic cranial nerves. Whenever that is getting stimulated, acetylcholine is released, binds with the receptors, produces these symptoms. And acetylcholinesterase enzyme will bind with the anionic and esteratic site, tend to break down the acetylcholine. This is what your physiology is. But when a patient takes up organophosphorus compounds as an overdose, when a patient takes up organophosphorus compounds as an overdose, it is going to be inhibiting the acetylcholinesterase enzyme. How it is going to get inhibited? Again, we'll be drawing the same thing, my dears. This is your acetylcholinesterase enzyme. This is acetylcholinesterase. We have anionic and esteratic site. And the organophosphorus compounds is a one which will bind only with the esteratic site. Organophosphorus compounds will bind with the esteratic site. Thereby, it is going to be inhibiting the acetylcholinesterase enzyme. Organophosphorus compounds will be inhibiting the acetylcholinesterase enzyme. Well, that is the mechanism over here. Now, for the first question, in which site this organophosphorus compound is binding? Is it binding with the active site or allosteric site? As I've explained previously, acetylcholinesterase enzyme contains two sites, two active sites, anionic and esteratic site. Organophosphorus compounds is binding up with the active site, so that's why organophosphorus compound is actually a competitive, but it is binding up to produce an irreversible inhibition of acetylcholinesterase. How it is going to be producing? When organophosphorus compounds binds with acetylcholinesterase enzyme, it will convert a normal acetylcholinesterase to MIP acetylcholinesterase. The full form of that is monoisopropyl phosphoryl acetylcholinesterase enzyme, but don't worry, simply acetylcholinesterase enzyme is getting phosphorylated. This process is what we call as aging process. Whenever aging process is getting completed, the inhibition is getting moved on to the irreversible complex. And that's why we have to intervene with the help of oximes even before the irreversible inhibition is taken care of. Now we'll proceed on further. As I've told, it is a competitive, what type of an inhibitor? Irreversible inhibitor. This is a classical example, my dear. You might be expected, this question might be expected in the MCQs or also in your Vivas. Very much important one, a classical example of a competitive irreversible inhibitor. Why is it very much important? Because competitive inhibitors are mostly reversible in nature. Non-competitive inhibitors are mostly irreversible in nature. We have a beautiful collab over here, competitive and irreversible inhibitor, which is organophosphorus compounds. Okay, we have finished about the physiology. We have explained about the mechanism of how organophosphorus is producing its actions. Now, what about the clinical features, my dears? Simple one, there is no need to write down, because the clinical features of organophosphorus compounds are nothing but SLUDGE BBB. You can just repeat it back again. In your exams, no one is asking you to write down the physiology, but if it is going to be a long answer, they're explaining, they expect a lot from you. You can write down the physiology, and followed by that, you can start from this pharmacology. But if it is a short answer question, you can just start from this page itself, organophosphorus compounds and its inhibition, and you can write down the clinical features as SLUDGE BBB and write down completely, salivation, lacrimation, all these things can be written below that. The second one, how do we diagnose a case? How do we diagnose a case of organophosphorus compounds? Mostly it is based on clinical features, my dears. Mostly the diagnosis of a patient suffering from organophosphorus compounds poisoning is based on clinical features. But if a question is being asked, which clinical investigation, which laboratory investigation can be done for diagnosing a patient with organophosphorus compound, the answer is going to be RBC acetylcholinesterase activity can be taken care of. RBC acetylcholinesterase or RBC pseudocholinesterase activity can be taken care of. By measuring this activity, we can classify, we can find out whether the patient is suffering from an organophosphorus compounds poisoning or not. But you know what? Most easiest thing to diagnose, just take a smell of it. OP poisoning, most of the patients will be having clear-cut smell of it. When a patient has been put up to you, there in the IMCU, patient is put up to you in a structure, and the patient's relatives are saying, we don't know, somehow he collapsed. And you can just, when you go nearby the patient, you can clearly smell the presence of an organophosphorus compounds, very much pungent smell. You can clearly see it. Sorry, you can clearly smell it. So based on that, you can easily diagnose the patient. Okay, so we have finished the mechanism of OP poisoning, clinical features, sludge BB, you just write it down, and diagnosis, clinical features, and RBC is acetylcholinesterase activity or pseudocholinesterase activity. Moving on to the last one, or simply as per the actual concepts of pharmacology regarding the treatment process. Regarding the treatment of an organophosphorus compounds. Here we are going to be writing down 5 important points, guys. Only 5 points are there, be it a long answer or be it a short answer. Only these 5 points are going to be expected. First point, if a patient is suffering from, because we know bronchospasm might be developed, patients might be landing up in hypoxia. In those conditions, I have to administer 100% oxygen. 100% oxygen has to be administered. The saturation has to be maintained. If a patient is presenting up with severe respiratory depression, we have to start intubation as early as possible, which is what we explain as RSI, rapid sequence intubation. If at all is necessary, we can start the intubation. And whenever you are putting up the patient for intubation, the patient has to be put under a skeletal muscle relaxant agent. And that skeletal muscle relaxant agent of choice for OPC poisoning is rocuronium, my dears. Succinylcholine is contraindicated. Usually for any of the cases, we can use succinylcholine for the RSI rapid sequence intubation. But if the patient is suffering from OP poisoning, succinylcholine is contraindicated. We have to opt for rocuronium. The second point is over. Moving on to the third important point, which is decontamination. What is this decontamination? Of course, we know because organophosphorus compound is highly lipid soluble in nature. So in those lipid solubility, we have to make sure that the drug is not getting absorbed directly from the skin itself. So immediately we have to remove the clothes of the patient. We have to remove the cloth of the patient. We have to go with vigorous irrigation of the skin of the body throughout. If a patient is coming up to you, if a patient is a female patient, don't immediately ask for this particular strategy. You just have to confirm with the diagnosis, and after that you can proceed on further. And please make sure you follow all the precautionary measures whenever you're doing any procedures with a female patient. So remove the clothes, and we have to go with vigorous irrigation. And if the patient presents within 1 hour, if the patient presents within 1 hour of ingestion, you can go with activated charcoal. Post 1 hour, there is no use of it because most of the drugs is going to get absorbed into the blood. Activated charcoal will not be of most of any use in those cases. Now the next one, the fourth important point is, if a patient is presenting with seizures, you can go with benzodiazepines. Benzodiazepines like diazepam or midazolam or lorazepam can be administered for the treatment of seizures if a patient is developing that. Usually we administered around 10 milligrams via IV route. That's how we manage the seizures if a patient is presenting up with. These are the non-pharmacological managements, guys. 4 steps we have explained till now. Number 1, O2 therapy, intubation. Number 3, decontamination. Number 4, benzodiazepines for seizures. Now moving into the actual treatment process for organophosphorus compounds poisoning. First of all, we'll start with atropine. What exactly is the mechanism of action of atropine? Simple one. This atropine is a drug which will go and bind. We'll write it down here. Atropine is a drug which will go and bind with this muscarinic receptor and tend to block it. So whenever the acetylcholinesterase enzyme is getting inhibited, even if acetylcholine is getting accumulated, none of that can be able to bind with muscarinic receptors to produce the sludge BBB syndromes. In the meantime, OPC will be gradually metabolized and getting thrown out from the body. So we can prevent the patient from dying because of respiratory failure. Please also note down the cause of death in a patient with OP poisoning is respiratory failure. So we'll just proceed on further. Atropine, why we call it as, please don't call it as an anticholinergic drug. Always call this drug as an anti-muscarinic drug because there is a more specific nomenclature, my dears. This atropine, how do we administer, guys? We have to administer it both for mild OP poisoning and also for moderate to severe OPC poisoning. What exactly is this classification, guys? Mild and moderate or severe. Be it any kind of OPC poisoning, the first treatment of choice is going to be atropine. Mild means patient is presenting up only with meiosis and rhinorrhea. Patient is presenting up with only meiosis and rhinorrhea, we can classify the patient as mild OP poisoning. With any of the other symptoms, If any of the other symptoms are present, patients might be diagnosed as moderate to severe OP poisoning. What's the take-home point? Why do we need to classify that? Because for a mild case, we have to start administering atropine at a dose of 1 to 2 milligrams via IV route. Whereas if it is moderate to severe, we have to go with 2 to 5 milligrams via IV route. Sir, the doses are necessary or not? Most of the patients, most of the students are actually asking them the question whether to remember doses or not. For emergency cases, you have to remember the drug dose. Only for emergency cases like status asthmaticus, status epilepticus, OPC poisoning. In those of cases, you have to remember the drug dose. At least one primary drug which we give, you have to remember one drug dose. That would be enough. For example, we have 4 or 5 drugs to be given for that. For all those conditions, there is no need to remember the drug doses of all the drugs, unless you are preparing for a prescription writing or prescription audit. Only for those conditions, you have to remember the drug dose. But for theory, there is no need to remember the drug dose. Hi, Karthik. Hi, Ravi. Good evening, everyone. Yeah. Now, this is the dose of atropine to be given for mild and also for moderate to severe OP poisoning. Now, how frequently we have to administer it? The dose has to be doubled. Remember, as I've told, you just need to write down this whole flowchart. That's it. No one will be asking you any questions from that. That's going to be fetching you the maximum marks, because most of the students who are following that have secured multiple different marks in their exams. Dose is doubled every 3 to 5 minutes. Dose is doubled every 3 to 5 minutes. Till what time? Again, one more question. We have to stop it. When should we stop? We have to administer it till the bronchospasm is getting relieved. Till bronchospasm is relieved, we have to administer atropine. That's it. That's it about the classical features of atropine, guys. The second or the last important point to remember is the oxime drugs. What exactly are those oximes? Oximes are those group of drugs. Out of this, we have to remember only one drug, which is Pralidoxime. We have to remember only one drug, which is Pralidoxime. Of course, we have Obidoxime, diacetyl monoxime. Don't worry about the other oximes. Just remember one drug from every group. That will be enough for your exams. So Pralidoxime, what is the mechanism of action of it? We'll be drawing the same diagram right here. Here we have acetylcholinesterase enzyme. As we have explained, this is your anionic site and esteratic site. This is your acetylcholinesterase. And we have organophosphorus compounds, OP molecule. So here, as I have explained already, organophosphorus will be binding up with the esteratic site of the acetylcholinesterase enzyme. Pralidoxime drug, the drug which we administer, will go and bind with the anionic site at first. Okay, Pralidoxime will go and bind with the anionic site. Actually, it will sit down in the anionic site. It will it will form a bond with this organophosphorus compounds. As we can see over here, it is forming a bond with the organophosphorus compounds. Thereby, it is throwing the molecule out from the acetylcholinesterase enzyme. We have the Pralidoxime. We have the organophosphorus compound, and we have this bond which is formed between that. Okay. So simply, acetylcholinesterase enzyme is strongly bonded with the organophosphorus compounds. The Pralidoxime will come and bind with the acetylcholinesterase enzyme. It will form a bond with the organophosphorus that throws it out from that, thereby reactivates the acetylcholinesterase enzyme. Simple one. You can either draw this diagram in the exams, or you can simply draw a flowchart. I will explain. I will write on the flowchart also. So simply, these oxime drugs will bind with the anionic site. Thereby, it will form a bond with the organophosphorus compounds. Hi, Narsim Reddy. Hi, good evening. It will bind with the anionic site. Thereby, it will form a bond with the organophosphorus. And that is what we explain as it forms a phospho-oxime complex. This is explained as phospho-oxime complex. Phospho means organophosphate, oxime means Pralidoxime. So phospho-oxime complex will be formed. Thereby, it will reactivate acetylcholinesterase enzyme. It will reactivate acetylcholinesterase enzymes, and that's also one of the reasons why these oximes are also called as acetylcholinesterase reactivators. That's why it is also called as acetylcholinesterase reactivators. Remember these points, guys. Either you can draw the diagram. If you have enough amount of time, you can also draw the diagram and draw the flowchart. Please note down that in your exams, as much as possible, try to write it down with the diagrams or flowcharts or mind maps. Only that thing is going to be securing as much marks as possible, because we are going to be using a minimal time and getting a maximum mark out of it. You might think that, oh my God, it's very much lesser. I need to write down theory. No one will be asking you for theory writing, right? If whenever we are opening the pages, because I'm also working as in a medical college also. So whenever you're opening the paper, when you see a full paragraph written over there, no one will be reading that. They'll be just looking for the key points. When you give those key points like flowcharts or in diagrams, it's going to be getting a very good impression on that. And of course, please use a lot of colors in the exams. It will matter. People will be saying that it will not matter. No, because most of the people who are correcting the papers are primarily who are getting addicted to colors. Because whenever you go, because we are getting monotonous, guys, we have to correct some papers. No, like everything will be some nowadays is going to be happening in the systems also. There's going to be camera monitored. We have to sit down before the systems. We have to read all the points. It's getting monotonous. When you give colors, when you give flowcharts, when you do a different thing, that is going to be cracking the examiners. Well, that's how we are going to be fetching up maximum marks as possible. Okay, so it's going to be reactivating acetylcholinesterase enzyme. The last point to be remembered, what is the dose of it? Dose, we can administer around 30 milligrams per kilogram via IV route. And please down, it is always given along with atropine. It is never given as monotherapy. It should always be given along with atropine, guys. These are all the classical points about OPC poisoning. Whenever a question is being asked in the exams, you just need to follow with that. Last important point, if you want to fetch up a little bit more marks, right? Like you're finished up with us, and if you're already very much good with the answers, if you want to fetch up a little bit more marks, you have one more point to be written down. Please note it down, my dears. Your atropine is there, no? Yes, atropine is effective against organophosphorus compounds poisoning, is also effective against carbamates poisoning. It is effective against both organophosphorus compounds and carbamates poisoning. On the other hand, oxime drugs will be effective against organophosphorus compounds, will not be effective against carbamates poisoning, because carbamates will be binding up with both anionic and esteratic site, my dears. Because if it is binding up with both anionic and esteratic, as I've told already, your oximes will need to bind with the anionic site to form the bond. Here the anionic site is not free. Then how can it be effective against carbamates? So it is not effective against carbamates because there is no free anionic site. We have 2 points which is seen pertaining to that. First point is there is no free anionic site. That's why oximes cannot be effective in those cases. Number 2, it follows through a process which leads on to a quicker aging phenomena. The aging phenomena will happen very much quicker. Why is it very much important and very much relevant? Because we have explained that already. Whenever aging process occurs, the inhibition is going to be irreversible in nature. That's also one of the reasons why oximes has to be given before the aging process. Oximes has to be administered before the aging process, because after that it is not going to be effective. Even it is forming that phosphorus complex, it is not going to be removing that organophosphorus out from the acetylcholinesterase enzyme. These are all the classical features of it. Now, sir, okay, so you have explained, you have given me a long answer. What if I need to remember like few points just before the exams? I will highlight those points. You just need to remember those highlighted points, my dears. Point number 1, you have to write down that they will be searching for this point. These are all the key points there. You have to write down organophosphorus compound is a competitive irreversible inhibitor. First point must be written. Second point must be written the clinical features, because most of the points they will be explaining about that. Even one of the subset of a long answer, they will be asking you what are the clinical features of organophosphorus compounds poisoning. So clinical features extremely important. And the next important one is atropine. The third point is regarding atropine and how atropine is going to be useful for that. And the fourth one is regarding oximes. Even if you can't remember any of the other points, you have to remember these 4 important areas: competitive irreversible inhibitor, organophosphorus compound, then the clinical features, SLUDGE, BBB, the important points regarding atropine, important points regarding oximes. Well, that's it. A small 2-second recap of what we have explained about till now. We came up with the like physiology of how acetylcholine is getting released, how it is binding up with the receptor, and what is that sludge BBB, the muscarinic symptoms, how acetylcholine is getting broken down by acetylcholinesterase enzyme. We explained about the physiology behind it. Then we started with the actual long answer to be written up. Acetylcholinesterase enzyme, organophosphorus will be binding only with the esteratic site, and it will produce something causes aging monoisopropyl phosphoryl acetylcholinesterase enzyme. And we explained about the clinical features. How do we diagnose that with the help of RBC, acetylcholinesterase activity, or pseudocholinesterase activity? Treatments, we explained about 6 points over here. 5 important points. First one is 100% O2, which is intubation and O2 will be clarified up together. So either you can remember it as 6 points or 5 points. Intubation, which is the drug of choice, rocuronium, MCQ point. Decontamination, we can use activated charcoal. Again, one of the important MCQ question. Benzodiazepines can be given for the treatment of OPC-induced seizures. And atropine, which is an antimuscarinic. For mild, we can give 1 to 2 milligrams via IV route. Moderate to severe, 2 to 5 milligrams via IV route. Dose must be doubled every 3 to 5 minutes till bronchospasm is getting relieved. It is effective against both organophosphorus and carbamates poisoning. Oxime's example, Pralidoxime is the one which will bind with the anionic site of the acetylcholinesterase enzyme, forms a phospho-oxime complex and reactivate acetylcholinesterase enzyme, and that's why it is also called as acetylcholinesterase reactivators. The dose which we administer is 30 milligram per kilogram given via IV route. Always it is administered along with atropine. It is never given as monotherapy. It is useful against organophosphorus. It is not effective against carbamates. Why? Because of 2 reasons. There is no free anionic site, and the aging process, the conversion to monoisopropyl phosphoryl acetylcholinesterase process is going to be quicker. With this, we complete today's session, my dears. We'll meet up in one more session. As I've told, we'll keep it as crisp as possible. None of our session will be crossing more than 30 minutes, and these notes are extremely high yield. You just need to read that just before the exams. All the best. We'll meet up in one more session. Bye-bye.